Well, good morning, good afternoon, everyone, and welcome to today's webinar for the RSNA 3D Printing Special Interest Group. We are having the team from MD Anderson, Sujaya H and Salah Rahman, talking about 3D printing reimbursement that includes perspective for both new and established labs. And as a side note, just a little introduction on who we are. We are an organization part of the RSNA, which has over 52,000 members from 153 countries around the world. And the mission of the RSNA is to promote excellence in patient care through healthcare delivery, education, research, and technology. The SIG is a dedicated group that you can join through the RSNA, and our goal is to deliver the highest quality of 3D printing in medicine through both education, collaboration, and research. And we focus on having a role for radiologists as well as the allied health scientists and physicians involved in this work. You can join anytime. If you want, you can scan that QR code. So we have several subcommittees that focus on education with the co-leads of Summer Decker and Rob Pugliese, appropriateness criteria or guidelines, which is being led by David Ballard and Frankie Ribicki, as well as quality assurance led by Nicole Wake and Laura Gilmore, and our outreach subcommittees led by Ben Johnson and Todd Patila. So check out our page. Once you become a member, you can see a lot more details on how to join and participate in these subcommittees, as well as this and other future activities and webinars. On today's presenters, you can see that we know them very well. We have Sujaya H. She is the director of the Division Research Development for the Division of Diagnostic Imaging at the University of Texas MD Anderson Cancer Center. She has over 20 years of experience creating, launching, and implementing novel initiatives, which is how she has joined the 3D printing initiative in the institution. She oversees also clinical trial operations, as well as having co-founded a very novel way of standardizing imaging analysis in clinical research and the development of a quantitative imaging analysis core. In this role, she's worked with both the administration side, operations, as well as radiologists. Salah Rahman is the director of authorizations in the Financial Clearance Center at the University of Texas MD Anderson Cancer Center, and he leads the team that evaluates the need of pre-authorization and predetermination, and we'll learn that there's a difference of those in medical 3D printing services. He brings over 25 years of experience in IT and operational management for patient access, revenue, and project management. So with that, I'm going to let our speakers begin.
Thank you, Dr. Santiago. Can everybody see my screen here? Oh, okay. So, thank you again for having us speak this afternoon. We're excited, and I hope that whatever we share with you, you can be just as successful at your own institutions for getting reimbursement for 3D printing efforts. So let me start by saying that we have no financial disclosures or any conflicts of interest to reveal, especially with the material presented today. So let's start with what steps did we take? Well, one of the first steps we took were to identify the right partners to make this a success at our institution. First, we met with folks in EPIC, which is our EHR, because it was really important to incorporate the orders or the orderables for requesting our services for 3D printing here, and to embed them within our EHR to make it easier for the providers to request. So really important to make friends there. The next group that we engaged early on were the folks called Clinical Reimbursement Pricing Team here. Again, these are the folks that take a Category III code or just a Category I CPT code, and they price it based on our institutional standards, if you will. And I'll get into the details in a little bit. And then there's the folks in financial clearance, including my partner in crime today, who you'll hear from shortly, who help with the workflows and the actual processes involved to clear with commercial payers, et cetera, to getting this bill successfully. And of course, though the first three are just as important, we wanted to make sure that we also engage early on with the patient business services, who in our institution are the ones that after patients have been billed, they do some review and analysis to see that we were actually getting reimbursement back. So it's really important that we engaged with them early on as well. So this is sort of a screenshot of how our orderable looks in Epic. You could see here, we talk about, when is the expected date of the surgery for the patient. We need to ask what the reason that they're requesting for this 3D printing. Is it just for maybe educational purposes, or is it for pre-surgical planning, et cetera? And of course, all the other stuff regarding their anatomy to make this a successful model for the patient's upcoming treatment or surgery. And here's a snapshot of the financial clearance workflow, work queue, again, which Salah and his team were helped us make sure that this was in place. So this is the work queue that our 3D printing engineer actually looks at. And if I can take you over here to this little check mark, this is what we see when things are good to go. So we get the green light. If this patient's information wasn't successfully cleared through financial purposes, then it would be showing us an X, which means we wouldn't do any further work for that particular patient's model, if you will. And I just want to make it clear to everybody that I'm not breaching PHI here. This is actually just a local brewery here in Texas. So just a screenshot here again that we look for this green light to move any further. So let's talk a little bit about the procedures and the cost analysis, right? So the Category III codes that were released included these four here. The 0559T is for the actual anatomic model, and which I call a parent code, because there's a supplemental code to it also, which I refer to as a child code. So, and then there's a parent code for the surgical guides as well, which is the 0561T. And then there's a child code associated with that, which is the 0562T. So what do you consider? I think we worked with our pricing team again to come up with an actual charge in our charge master. So, but these four general things globally are what's incorporated to come up with the charge. Includes direct labor costs, which in this case are the biomedical engineers that you might have on site to help with the service. There's no faculty, there's no radiology component to this because this is on the technical side here so far. Then there's the equipment costs, which includes obviously the software materialized in this case that we use, any 3D printers. If you bought any with capital purchase, I strongly encourage you to put that in this sort of Excel sheet, if you will. Laptops, because you might want to do some modeling from remotely, if you will. And any consumable you can possibly think of, as little as sanding sheets to gloves, obviously the materials, adhesive, and any other thing that you could possibly think of to calculate. And then, of course, this is the secret magic sauce that's really dependent on your institutional standards, such as depreciation, the cost for utilities, and obviously the institutional overhead. So these four things together give you that specific charge that should be in your embedded into your charge master. Let's see how we kind of apply those Category III codes that I spoke of. So this, just a sample to show you, this is the 0559T, which is the anatomic model code, and this is the child code that I referred to earlier, the 0560T. So if you were to build just this rib cage, if you will, that would be just the parent code, right? So that would be the one charge drop, and that's the 0559T charge. But in this, like, let's say you have this model here, you would build the parent code here, plus the supplemental code, which is the lesion of interest here. So you bill out these two charges. And then if you have a more complex case such as this, then you would bill out the parent code here along with its 7 children. So you could see how, the range of charges as well as the range of reimbursement as the models get more complex. I must say in our, when we piloted these charges or the reimbursement component, we were only billing the parent code first for the anatomic models. But now recently we've started billing out the supplemental codes, which have also come out to be successfully reimbursed as well. So now I'm going to pass the mic over to my colleague here, Salah, so he could speak about reimbursement from a commercial payer side. Thank you.
Thank you, Sujaya. It's great to be here, and thank you for having me. With financial clearance, especially here at MD Anderson, we essentially break things down into three major steps. Our first step within that financial clearance workflow is to check eligibility and benefits. That's standard for any payer that you have on the commercial side. What you want to do is establish whether or not the patient is, of course, in network versus out of network. The in network and out of network is pretty important, especially when you're looking in terms of reimbursement. If you're in network, a payer is going to pay a certain percentage versus what the patient will pay out of pocket. Out of network means a lesser pay as far as what the an insurance provider may do versus what the patient has to do on their side. The situation, because we're a specialty hospital, out of network does come into play pretty significantly, because we do have a large patient population that comes in looking for second opinions and things of that nature. So there's a lot of upfront work that we have to do to make sure that the patient understands what their financial responsibilities are in that situation. And after that's done, then of course we're looking at the individual services, whether or not they will be authorized by the payer based off of what their policies are. And that takes us into the realm of pre-authorization. And normally what we do here is we have a pretty large group of authorization specialists. We have over about 100 of them, and they're of course broken down by the top 5 payers and our governmental payers as well too. And we actually have work queues in Epic that help guide that process depending on what the payer is for that patient. As soon as the authorization process is kicked off, there may be situations within the actual payer plans where they also want, before they authorize, they also want to check whether or not this is medically necessary. And some of these payers do have specific policies associated to that. So on top of the authorization process, we're also asking them to do a predetermination where they will review all our medical notes and everything for the justification to say that is this medically necessary or not. And you want to do that, because if you don't do that, say for example they give you the authorization, but once you put the claim in, they can go back and review it and then deny it based off of medical necessity. So you want to try and get that done up front, so that pretty much guarantees that you won't be denied for medical necessity. And some of these payers do have clauses in there that state that. They may say no auth required, but we need to do a pre-D. And you'll see that in the coming slides. So next slide. So as I stated just briefly, that the way we do our authorizations, we actually have Epic work queues, and we actually break them down by our payers and our government plans. So think of the United Healthcare insignia that you see here that doesn't require any authorization, right? So we actually have a specific United Healthcare insurance authorization team, and that's all they do is process financial clearance for that payer. So they're pretty versed in the policies and rules associated to that payer based off all the services that are provided within their contract. And UHC is pretty significant, because what we do have is an individual contract with them that allows for the authorization of diagnostic imaging services and other high dollar services at a set reimbursement. So that means we don't need pre-authorization. So anything that our providers, if the patient has UHC, then our providers are getting that green check mark as soon as they order that particular service, like you saw on the screen that Sujaya highlighted. Cigna, we also reviewed their policies. They don't require authorization for this service. We don't have anything individual contracts with them, but most of all their plans do not require authorization. So what will happen is our system will evaluate that and then automatically place that green check mark for the providers to see so they can proceed on. Next slide. Now, this is where we talked about the pre-D. Aetna, for example, they'll always say no auth required, especially for some of these types of services, but they will offer a pre-D. If they're offering that pre-D, you should take it, because if you don't take it and if they don't evaluate it, then you'll be submitting a claim that will end up getting denied due to medical necessity. Aetna is pretty complicated because they have these access networks where if you're not paying attention to that particular insurance card and looking at it closely, they could have exclusion criteria, especially if some of the services may be out of network, while other services are in network. So Aetna is kind of tricky that way. So you need to make sure that your insurance folks are paying attention to Aetna because of this requirement. Humana is a small volume on our end, but they always require authorization. It's just standard. There's no special, guidelines, but they'll need that pre-certification, and usually that could take anywhere from 2 to 15 days, depending on what the emergency criteria is that we're submitting for. Next slide. Now, Blue Cross is by far our largest commercial payer here. They represent close to about 60% of our commercial business, probably even higher on our end. And Blue Cross is pretty unique because it's not like a national plan like UHC and Cigna. Blue Cross has different plans, and they're broken by state. And within each of those states, you could have employer-based plans that also put in their own rules associated to that. So with Blue Cross, you're always going to need some level of authorization, and you have to really pay attention to their policies and procedure by state. As you can see, this is kind of a snippet of what they have, and this is coming from Blue Cross of Texas, PPO. So we have a very large group of as far as our Blue Cross authorization team goes. We have over 30 specialists working on Blue Cross just to process patients through. It used to be Blue Cross was easy to process, and you'd get done. They were like one of my favorite payers because we can get things taken care of. But recently, they put in a lot of medical policies, restrictions, and things of that nature, where it's actually they're becoming one of our difficult payers as far as getting things initiated and quickly done on our end. Next slide. So this applies to Texas. What's happening here is that from a standpoint of Gold Card, when you hear Gold Card, what you're hearing is that think of it as auto authorization, if you will. Basically, what that means is if you've got a contract like we have with UHC, you don't have to do any type of clearance whatsoever. You can just schedule and be on your way. Now, this House bill that was just passed allows for some relief when it comes to pre-authorization. And the way this works is that if you're a provider and you order a certain service, and if that service was approved for the last 5 times that you ordered on different patients, then you qualify for this gold carding process, which basically means is that, say, for example, you ordered a CT and it was approved for that, the last 5 times, then you don't have to seek authorization for the next year. And that's huge from a authorization standpoint for all services, because it pretty much reduces the time it takes to get patients through the door and get their services done, and it pretty much guarantees that you are going to get paid for your service as well too on the back end. So this applies to Texas fully insured plans, and our team is actively looking at how we can get that into our system. We do believe that it will impact 20% of our patients as far as getting services through the door, and it also impacts these types of services as well too. So we're still evaluating exactly how that workflow would look, considering it's by specific procedure on our end, so we'll have to put in rules in our system to target that, along with expiration dates of how far we can go without no auth for particular providers as well too. So more to come on that. We're still trying to figure it out. Next slide. So this is essentially our reimbursement slide. As you can see, we're pretty successful in getting reimbursed for the services, especially on for these types of services that we have here. The only issue, of course, is Medicaid, which is standard. It's not that great. I mean, we do also see patients that are out of state, and they come in with out-of-state Medicaid plans, and we know that we don't take them, but we provide that service for them anyway. So we know that from an institutional standpoint, we do have this acceptable criteria that says that we're going to proceed on in situations like that. So we have an understanding that Medicaid, we're not going to get a whole lot of reimbursement on their end. And that's it for me.
Yeah, thanks, Salah. I think we're open to answering any questions you may have.
Thank you, guys. I have a couple of questions. Obviously, this is a very different world that you guys are managing, and you are very comfortable with that end. From one of your slides, you mentioned the predetermination process can take up to 15 days. Sometimes we encounter that 3D printing services can be requested more emergently. How do you guys work with the payers to bridge that timeline?
So some of these payers will have a direct appeal process as well that you can escalate that to. And what will end up happening is at that point, you're looking at a peer-to-peer discussion and an appointment that you're setting up with them to do that. Payers do have things built in where, you know, if it's going to take 15 days, like say, for example, Aetna, they have something that says that, you know, you can go ahead and call their nurse line and then request it to be escalated, and they'll look at it within the next 2 to 5 days. And that's just Aetna. Each payer is different, but they do have a process where you can do that.
And Sujaya, we have another question coming up on the chat, on the Q&A, in terms of the reimbursement being similar to other T codes that you have worked with for other non-3D printing services. And was it difficult for payers to recognize that technology as reimbursable?
Yeah, that's a great question. I would say I have worked with category T codes before, and I think it all depends, right? I think generally over the last 10 years, I'll tell you, I've noticed that the commercial payers are more open to reimbursing those category T codes. Early on, when we were dealing with devices, if you will, that had a category T code, like an interventional radiology, if you will, we had a lot of issues with reimbursement. But I think in the last 10 years, and Salah, you can correct me if I'm wrong, but I think the payers are just more open to reimbursing those, especially with the more complex cases that we deal with day to day here.
And so we have another question coming, and that is, how do we process a 3D printing request from interdepartmental requesters and reimbursement?
So again, if it's something clinical that can impact the patient's care, it's the same workflow. The provider would put in an order through Epic, and we would service it, as I explained earlier. If it's not clinically impacting the patient's care, we do have another workflow that sits outside of Epic, where we have a whole nother cost structure that we've defined for research only, if you will.
Mm-hmm. Exactly. So the question was mostly driven towards research, correct? In addition, another question coming through the chat in terms of the reimbursement process or how the payers receive the process, depending on the type of 3D printing case. Have you seen any differences in the indication based on anatomy, the application, or are you finding that just as long as it's justified, medically necessary, it's being accepted by the payers?
It's usually just it's medically necessary, then it'd be accepted by the payer. We're not seeing a whole lot of differences. What we are seeing is if it's a state, like Blue Cross, for example, you're from a different state, but if it's also an employer-sponsored plan, then that employer may put in restrictions for these types of services, in which case, at that point, it's more of a benefits discussion with the employer that the patient has to do to see if they allow that type of service.
Mm-hmm. And Salah, another question that refers back to the statement you made in terms of Blue Cross, Blue Shield varying state by state. The question is how
I think the screen is frozen, but let me go ahead and look at that question here. Okay. You mentioned Blue Cross Blue Shield varying state by state. How transfer with some of the efforts you've been made? Do you think it would be worthwhile to connect everything? I'd be happy to connect with some of your financial teams. It's a little different. We have system rules in place that look at some of these individual policies, and they produce a lot of these flags that help guide our associates in getting the authorization. So it is something that, you know, we have processes built in. So I don't mind actually reaching out and speaking to some of your financial teams on how you can build that. I'm assuming we're all on, hopefully all on Epic, because a lot of these things are built in to what we're doing in our infrastructure there.
I think the next question is for you as well, in terms of levels of reimbursement.
That's something I'd actually have to reach out to our reimbursement office for. That I do not know offhand at this time. But all I can tell you right now is that if there was any problems of them not reaching our reimbursement, our reimbursement folks would be talking to me right now as far as, you know, authorization and upfront clearance goes. So I need to check with our clinical reimbursement folks to actually take that back and answer that. That's okay.
Yeah, and I'll go ahead and read the next question from Prashant. It says, great, okay, what percentage of clinical cases needing 3D printing are you able to get successfully reimbursement? So to answer that question, we only piloted the reimbursement component, if you will, with 26 cases so far. And so the data we're sharing with you are only related to those first 26 cases. But now that we're comfortable and confident with the reimbursement we're receiving, we're obviously going to expand and scale higher. And then there's another question here. It says, how do you mitigate issues on your end whenever a 3D printed part does not meet its purpose? So that's a great question too. So we do a lot of upfront work, and unfortunately, I think Dr. Santiago had some issues here, but we do a lot of upfront work with the consultation component for 3D printing prior to us even engaging and actually going so far as to building that model out. So far, we haven't had an issue where, quote, the part isn't quality controlled enough, if you will, to not meet its purpose. So we do our due diligence upfront. So we've addressed the questions so far. So there's another question from Millicent here. Are there any regulatory requirements for maintaining a 3D printing lab within the hospital as provided? So we worked with EH&S, Millicent, to answer your question, to ensure that at least the space meets the regulatory requirements. But I'm not sure what you're referring to in terms of regulatory requirements. We are now only printing the anatomic models. We're not really going into the space of surgical guides that actually touch a patient, if you will, or any implantables or any other invasive components that might be deemed as medical devices. So we are now just printing the anatomic models. So no, there are no additional regulatory requirements that we're needing for that. And Varun here wants to know our monthly and yearly 3D printing requests. Again, this is a pilot phase, and we have, and I'll be open with you in terms of, we have one biomedical engineer, so you could understand that our efforts to scale is going to be a phased approach at our institution. And I'll let Dr. Santiago answer that question in terms of volumes and requests.
Mm-hmm. So for clinical cases that basically are in alignment with the talk heard today, we have about 2 to 4 monthly cases that we're processing. Again, that does not include non-clinical work that we do as part of the 3D printing lab. And we have another question for the coding from Ken, where the child code, the 0560T codes being billed for complex multi-part model, how would the reimbursement scale be? Basically, is there a diminishing scale for the number of parts?
No, there's not. I mean, the more you bill, the more we're getting reimbursed. The sum total determines the larger reimbursement as a percentage.
And I think we've all experienced that variety or diversity in the 3D printing models being requested. Sujaya, you showed from a single part to a multi-part model. So obviously, the amount of work, material, man hours varies from model to model.
Correct, yeah. So higher acuity, higher reimbursement.
And I have another question. In terms of launching this process, I'm curious to know, how did you coordinate the different teams that you touched points with? I think in the beginning, you presented a slide that detailed the EPIC team, reimbursement team. I think in total, it was like 5 teams. How and in what order did you approach these teams?
Yeah, so the first thing I thought about was like, how do you even request the service? So if you think about it from cradle to grave, if you will, you start with the orderable. Once you order, what's required next? Financial clearance. So then, so you need a pricing, right? You need to understand what the price is that's in the charge master. So then you engage the pricing team. Then you go back to financial clearance saying, okay, we have a charge now. How do we then work with you to ensure that the patients are cleared financially so that we can begin the work? So it's sort of like, I hate to put it, but this is an analogy like Starbucks. You go in there with like a large cup so they know to grab the large cup first, right? So you do it methodically based on our actions.
And can you speak a little bit about the timeline for each of these steps, just so that especially a lab that had a particular process understands maybe how switching over to billing a Category III code may take for them to implement?
Yeah, I wish I could say we got it done in like a week, but no, I'd be lying. I mean, this was a this was a according to MD Anderson time, it was done pretty fast. I would say we took a year and a half. Mind you, this also happened during the pandemic when we were still trying to figure out what we could offer, what we could not offer. So the timing wasn't the greatest for us to start this new service line here, but I think if you know the right people already, then obviously you have you can expedite this much further. And I think, having people that are really engaged early on really helps, and you kind of learn from each other. I mean, seriously, with my partner here, with Salah, I mean, he's taught me so much, and having him sort of become your friend over the time really helps. So we can always like sort of call on each other and say, hey, what's going on with this or what's going on with that. So I would say, to answer your question, about a year is what you should look at to work with these various components. Again, it's also based on the size of your institution too, right? So we're a pretty large comprehensive cancer center, so it takes a while for others to prioritize the workload.
And Salah, what would be your suggestion for, let's say you have a team that's working in a 3D printing lab off in the lost land of diagnostic radiology, and they've never interacted with financial clearance, reimbursement, or any of those components. How or where can they look up the members of that team at their institution?
Well, hopefully the institution, whichever it is, they already have a designated team that handles it and it's visible. Usually it could be in a patient access team that handles it, or in this case, we're not patient access, we're a financial clearance center, right? So the team should already have visibility. I'm hoping that they do, because in services like this, you're always going to need some centralized team that manages your financial clearance. MD Anderson used to be decentralized back before we implemented Epic, and it was pretty chaotic. And if we were to implement something like this back then, it wouldn't have been a year and a half. It would have been 2-3 years, because ultimately you've had 50 centers having their own clearance centers trying to do things, right? So hopefully our partners over here have centralized financial clearance areas where they can reach out to. Like, everybody knows when we're talking about MD Anderson, they know if there's financial clearance, just contact the FCC, right? So I'm hoping in a similar fashion that there's some sort of centralized clearance area in these hospitals, in the other areas.
And another question from the Q&A from Ken, noticing that Medicaid was one of the payers that is not currently reimbursement. Have we historically noticed that Medicaid is one of the biggest challenges with new technologies?
From my end, from a financial clearance perspective, yes. I mean, there are several steps behind when it comes to identifying new technologies and processing them to ensure that this is part of the patient's treatment and it's a need. It's been historically, I've been in the financial clearance realm for a long time. It's just been that way. That's just how they are in terms of that. And it's a constant battle. I will tell you that. Outside of this service and including other services and treatments, especially we're a cancer center, so we do have a lot of new drug therapies and things like that take place, which it's just a battle with them. We prefer not to take that, but we don't have that luxury either.
And another question coming from the chat in terms of the negotiations with each payer to establish the reimbursement process. You mentioned that you have specialized teams. So the question is, what sort of justification was used to convince the payers that they were getting value for the reimbursement?
I can speak in general terms, and I'll use our UHC as an example. Prior to our contract, what we did was we looked at it. We looked at our authorization rates. We looked at our denials rate. and what was being approved. And when we took account 3 years worth of services that we did with UHC, we noticed that we got 90% clearance pretty much on all services, not 90% clearance. And what we mean by that is that they authorized it, and even if they initially denied it and we got a peer-to-peer and it got approved, that still counts as an authorization, right? So we looked at it and we just went to them and said that, look, in the last 3 years, you guys are approving 90% of all the services that we're ordering. How about giving us a flat rate, if you will, and so that way we could reduce our overhead and also reduce your overhead, because some of these insurance payers, they also have a tremendous amount of overhead, especially if they're having to do peer-to-peers and appeals. And we just approached it to the point where here's the data, you're looking at it, of the 90%, 40% were actually done through peer-to-peers. So at that point, do you want to just, why not just give us a contract with a flat rate, if you will? That way we don't have to worry about it and our patients can pass through, and you don't have to worry about having clinical folks on your end reviewing each case just to meet with our provider and justify why you can't have it or you can have it. So that's how we approached it for UHC, and that contract's been in existence for like 4 years now, and it's served us well. UHC, we're always happy when we see patients coming in with UHC, because we can tell our providers, proceed, go, do whatever you need to do, schedule them the same day if you want to on our end. So we're moving in that direction, and that's how we're approaching it. We're just looking at data, and you'll need a good data analytics team to really dive into your claims and the ordering services that you have to justify that.
And you mentioned that in the emergencies, a lot of patients from out of state. Have you seen a big differential in payers that are for patients that are in state versus out of state in terms of coverage, or is it about the same, whether their patient is from Texas or outside of Texas?
The majority of the out-of-state patients are we're really getting from our surrounding states, if you will, that are there, especially, and a lot of them are actually coming in on an emergent basis. But we have an emergency ACC unit that deals with that. So, and I would say about 40% of those patients are out-of-state Medicaid patients that are coming in, and they're needing the service because their local hospital or provider just can't provide that type of service, and you know, that continuity of care that MD Anderson can provide. So it's that bucket of patients where we have the most difficulty with, because we still have to follow our financial clearance guidelines. We're still going to treat them. We're going to do that, but we still have to, you know, have the counseling sessions, letting our providers know that they're not cleared, going through override processes and things like that on our end that we have to do for these patients. But a good chunk of them are out-of-state Medicaid patients.
Yeah. And another question coming from the Q&A, what types of information do you have to demonstrate for the predetermination?
So what we're looking for is it depends on what the service is, really. So if it's like, and it also depends on, you know, how long the patient has been seen, right? So if you're talking about a 6-month follow-up for a patient and they came in and they wanted to order CT, you're going to need 6 months pretty much of worth of clinical data to, you know, support exactly what they're doing. But a lot of that is going to be based off of what's in the medical policy of the payer. The payers will tell you in detail, like, we want to see 3 months worth of labs. We want to see, you know, your last CT, you know, notes that you took to justify, say, a PET scan, right? So they'll essentially tell you that. And when they don't tell you that, we are front loading as much clinical data as possible. And we usually put in close to about 2 to 3 months initially worth of clinical data in terms of labs, procedures, and of course, provider notes that are there when they don't specify that.
So a follow-up to that, let's say I'm about to initiate this kind of process and start billing in my institution. would it be helpful having the clinical teams requesting 3D printing services to put in their clinical notes a line item on the medical necessity for why in this patient the service is required?
We encourage that for every service. Honestly, you know, the more we're from an authorization perspective, we're a lot more successful when we have that information up front. Normally what ends up happening is when you don't have that information up front, especially with what you're just stating, there's a game of tag that's being played between our financial clearance folks and then the insurance, and then communicating back to the provider and the patient as well too. I've noticed that when we don't have that information, our cycle time, we usually add about close to another 3 or 4 days worth of cycle time when it comes down to it.
Okay. That was very helpful. And another couple of questions coming from the chat. Baron asked, do the radiologists put clinical interpretation on the 3D printing codes? I think Sujaya, you can answer this.
So the reimbursement right now is on the technical side. So there's no formal interpretation by radiologists yet. That we'll explore that so that we can try to recoup the PRS side of the codes hopefully soon.
And so the follow-up question which Ken posed is, as 3D printing is considered a technical charge, is there scope for a professional charge related to clinical judgment in making the models?
There's absolutely an opportunity to develop a PRS component for this code. I think that should be what the SIG should be working on next. So we'd be happy to participate to support that as well.
Mm-hmm. And I think the people that are working on 3D printing, we recognize that there's a lot of different touch points for radiologist involvement from whether you're in a small lab and there is no biomedical engineer, and so the radiologist is the one doing the segmentation, to a nice big established lab where the radiologist only verifies the segmentation. So there is definitely the space to add what is considered a professional component, right? If the technical charge goes for the hands-on part for the professional component, I think we definitely can do that. Recommendations for how to justify that professional charge. Sujaya, do you have any?
I think it's, again, a lot of data mining, a lot of capturing data in terms of how much are you spending, especially to focus on the quality control component, the segmentation component, I think would really expedite those efforts to qualify a PRS or a physician professional fees for this.
So I've heard from Salah a lot of looking back and auditing existing practice to develop your agreements and negotiating with your payers. I've heard a lot of looking back in data collection from Sujaya, just looking at the technical and professional parts of the 3D printing services. So it seems that you both encourage keeping track of your efforts through data, as well as some sort of routine audit of that data. Salah, how often do you guys audit your processes or with each payer?
We have quarterly reviews of each of the payers on our end, at the top 5. And what these quarterly reviews do is we're going through pretty much denials data, reimbursement data. And then we have our own scorecard for the payers internally that, measure them, because they're measuring the hospitals as well too. So we're doing the same thing with them. And that scorecard is in relation to, of course, pre-authorization rates, denial reimbursement, information. You know, these payers have systems that you have to log into to process things. So we're also putting a score to their systems that we're utilizing to get these services cleared. So there's a lot of scoring that we do, but it's every quarter. And when we sit there, we then, you know, present that to our executive leadership. And then when it comes time for, you know, the actual renegotiation of contracts and everything, we use that information, just like the payers are going to be doing the same thing on their side too. So it's every quarter.
And another question coming through the Q&A is what is the average turnaround time expectation from requesters? And I think this can be both in terms of getting the service cleared, or, you know, I use clearance as a very generic, as well as, I guess, the delivery of the service.
So I could speak on the delivery of service. I mean, we always say up to 2 weeks lead time is what we require. Again, that could possibly change if we have more business continuity with our one biomedical engineer. So as we scale, we'll hopefully try to reduce that to maybe 1 week. But for right now, we're saying up to 2 weeks lead time.
And
sorry.
We have been delivering from request to service basically within a week. We have been able to do that. I think there are many places that have heard the same expectation of they want it basically within 3 days, which, if depending on the 3D printing technology, it can take up to 2 days to print something, let alone segmentation, et cetera, et cetera. So Salah, in terms of turnaround expectations that you have felt from the clinical team, what is in general the expectation you feel the clinical teams have for the clearance for your services?
We generally ask that, you know, we get up to at least 48 to 72 hours lead time to get things cleared. MD Anderson and the financial clearance center that we have, we're geared towards automating as much as we can, meaning that we want to auto-authorize, meaning that if you're as a provider, you're putting that order in, the system is already looking at the plan and then stating that, oh no, we have a contract with them, you're good to go, you're auto-authorized. So that way, even an associate can't even touch the case itself, right? And we have that with some of the plans that was outlined in the presentation. But generally, we're asking 48 to 72 hours. Our goal is to get it done within 5 days, but it's usually sooner. So,
Thank you. And another question through the Q&A. Do you close the case in Epic after 3D printing, and do you request feedback from the ordering physician?
Great question. So the way our workflow is once we complete the case, yes, we end procedure, that's our lingo to say, okay, yeah, it's time to bill it. So yeah, the case is automatically closed. In terms of feedback from the ordering physician, yes, we've actually implemented a survey within REDCap to try to get the provider's feedback.
And this survey for the facilities that are participating in the RSNA ACR 3D printing registry, it's based on the questionnaire that is part of the registry. So you can find the data dictionary, you can find the questions in the registry and try and build your survey from those questions. That way, it's a lot easier to import and participate in the registry as it stands, but I believe we're going to have an update on the registry coming up soon. Again, sending you back to your SIG homepage to get more information on future activities. So a couple of additional questions on that, and that is, how do you close the case if you're not dictating it?
Yeah, great question. Again, we've built the workflow on the technology workflow, or the imaging technologists here. So there are already established workflows where the codes might just be on the technical side. So that's what we're mimicking. So when our engineer sort of closes the case, we're done. Just the technical charges build out.
So Sujaya, would you say that your workflow in Epic mirrors the traditional radiology workflow of start the case, the same as in the radiology informatics system, the RIS, where you start a case and then you end the case?
Absolutely, that's what we kind of used to mimic for we used the imaging technologist workflow to create this, so that we wouldn't have to reinvent, the wheel, so to speak.
So with that, the engineer role in Epic, how would you assign that role? And again, this is a question coming through the Q&A.
Yeah, so unfortunately, there's no engineering workflow, so you would have to mimic what it's called in Radian. If you're in Epic, it's the imaging technologist workflow.
Okay. And another question through the Q&A, and that is, how many cases are you planning to do for the pilot study and the future plans regarding the work?
So our pilot study has already been completed with 26 cases. So now and the pilot only included the anatomic model parent code. So now, as of last September, we've been billing out the supplemental codes to the anatomic model code as well. And we'll keep scaling based on our capacity in terms of our personnel.
So would you say that your goal is to look at least 25 cases where you have build the parent and child code to see effectiveness of reimbursement?
Absolutely, yeah, we'd like to duplicate that, yeah.
And another question from the Q&A, and I think many people have heard this question, and that is, who gets to keep the model when it's used for a surgical case, and what is done for the models afterwards?
Great questions, Ada. So, so the models right now, I mean, this is a conversation that we've started with our legal team to understand, does this qualify as data and who can, so to speak. We're also working with our compliance folks to ensure that the informed consent that they sign also includes some verbiage related to 3D printing as well. So that's a work in progress, so that we do the right thing. What do we do with the models afterwards? Right now, it's in the provider space, if you will. We're just collecting it until we understand legally what needs to be done.
Very good. And I think models, when they are delivered, they come with a little instruction manual, if we will, referring back to the imaging exam that they were sourced from, with a summary. And I think in most institutions, people would agree that a lot of the providers, the clinicians, are keeping these models in their offices. We encourage them to bring them back to the lab again, so that they can serve for future education projects. And a question in the Q&A, any plans to recycle materials for these models? So from the engineering perspective, there are many materials that cannot be recycled. They are undergone processes that the resin, especially if you're dealing with VAT, the resin cannot be recycled. So we consider recycling of these materials the educational component. Again, sometimes the models are requested for very complex diseases or complex anatomy, and they can easily be turned into educational models that can be used for medical students, residents, and fellows to study these complex diseases. So that is our way of upcycling the models. So we are coming to an end on our current webinar. We have our last question for today, and that is, can you comment on the range of reimbursement received for the 26 cases?
Unfortunately, I can't comment on the specific range because these are contracts specific to our institution with that commercial payer. So 0 to 100% is what I could tell you.
Absolutely. So again, I want to thank our speakers for today. and our audience that was engaged in a very lively discussion. The questions were phenomenal. Just want to thank everybody. And again, as a shameless plug of the SIG, I just want to remind everybody to join the SIG, and you can find us on the RSNA webpage. You can scan the QR code and you will be able to be on the know for this webinar, which is being recorded, as well as future offerings by the SIG. Again, we want to thank everybody for their time, and we look forward to seeing you again on our next webinar. So stay tuned, join the SIG. And I know I sound like a YouTuber, but we want you to join the RSNA SIG and continue these efforts so that we can work on reimbursement and providing the highest quality of 3D printing services for our patients. Once again, thank you to Sujaya H and Salah Rahman, and thank you to all the audience that was able to join us today. We look forward to seeing you again on an upcoming webinar.